Good morning, everybody, and thank you for having me to Paducah once again, one of my favorite places to come. And I've been here for many, many times and many things, but today's an exciting thing and something near and dear to my heart, which is colorectal cancer. How's your mic over there? You got it? Good. For those of you who may not know me, I am a pancreatobiliary endoscopist. I do ERCP. I take care of pancreatic cancer, esophageal cancer, biliary cancer, hepatic cancer. I diagnose probably 10 times more pancreatic cancer in my particular practice than I do colon, but that's what I do. 4 years ago, I was sitting around looking at the numbers, though. I had been particularly stunned by a couple of cases in a row I'd seen of colorectal cancer, particularly metastatic disease, as we sit in our multidisciplinary work. And I went and started looking at the numbers and the statistics, because I thought we were making huge progress on colorectal cancer, because everybody was working hard. Fact of the matter is, we hadn't changed the incidence or the mortality one iota in our state in the past decade. And that's despite the fact that amongst all cancers outside of cervical cancer, the early detection and screening strategy for colorectal cancer is unparalleled. Unparalleled. Because you not only can actually prevent colorectal cancer by removing polyps, but you also have the benefits of early detection in appropriate screening. So I started the Colon Cancer Prevention Project, which is a not-for-profit organization of which I'm no longer the president, which is great. And we've got a survivor now who's a president. And our job is essentially to eliminate unnecessary suffering and premature death through the state of Kentucky and our surrounding communities through education, advocacy, and systems change. And we know that increasing screening will reduce mortality. That does not need to be studied. We need no more work on that. What you see up here behind me is our latest show we did in Louisville. We've done 3-hour-long television shows, 2 in Lexington, 1 in Louisville. Eventually we'll want to do one here, next year. Hint, hint, let's partner up. And I've got DVDs, and I would want to pass these out to take home, which you can look at later, and I'm going to get to my presentation. But if there's 3 or 4 of you in an office, just try to take one and share it around for you. But I'm going to pass that around. Carol's going to help me with that. If you're interested in who we are, here's an annual report you might take a peek at. These are housekeeping duties I've got to take care of. We bought a bunch of brochures for offices, so please pick them up. It asks a very simple thing: are you at risk for cancer, colon cancer? For those of you who are movers and shakers, next Tuesday in Lexington is the Dialogue for Action, which is a statewide meeting about how we're going to address our colorectal cancer issue. Because, the problem is it's not just a problem, it's a really expensive problem. We're spending tons of money. We're spending a lot of it on chemo and advanced surgery and radiofrequency ablation and all this stuff that does nothing, I hate to say it for many people, but delay the inevitable, which is great. I tell people now, if you're going to have colon cancer, it's the best time ever. But it's still no time to have colon cancer if you can prevent it through screening. So for those of you, I'll pass these around. There still is registration. It's free, and you can sign up on there. And then the last thing I will do is remind everybody that in September in Louisville, we're going to have our 3rd annual Walk Away from Colon Cancer. And that's been an excellent awareness-raising event in our community, and we hope to raise over $100,000 this year is our goal. So without further ado, I'm going to move into this. And I'd love to show you a couple of clips from the television show, because they're so dramatic. What we've learned is the people who tell this story best are not guys like me who are boring and stuff, but people who've fighting this disease, people who beat this disease, people who were on the edge of, people who've screening saved their lives. I can't even begin to tell it as well as they are. So I'm going to turn this off, and you guys will check this out at a later date. But I want to run through some things. I worked in Toronto, and a lot of my friends were involved in the SARS case. You remember SARS? Severe acute respiratory distress syndrome. About 30 people died in North America for that, but it was on the news for 6 months. Amazing coverage. Hundreds of millions of dollars spent in our NIH, just everything for 29 deaths. Okay, well, I want to go ahead and paint for you a different picture of a different killer that over the last 10 years has affected, in the United States, more people than live in Seattle, Washington. And again, I want you to compare this to 29 people. 1.5 million people in the last 10 years affected by this disease. 600,000 people, the population of Philadelphia, dead with the disease that we essentially have the vaccine for. You know, cervical cancer used to be the #1 cancer killer in the United States of women in the 50s. It's still the #1 cancer killer of women in the third world, and even in Mexico, I found out recently. We would be appalled to have such a great screening test as the Pap smear and now the vaccine, and yet have that be such a devastating killer. And yet this is colon cancer in America today. You know, 29 people, 600,000 people. So we're going to talk today about a lot of things. We're going to talk about reinventing ourselves in public health to address things that are huge, but hard perhaps, over those things that are comfortable, but really not giving us a return on investment for what we're doing. But there is good news. I'll touch on this. This year we successfully, with the help of many, many partners, including the American Cancer Society, passed 2 landmark bills in the state legislature. One is Senate Bill 96, which is this is the 3rd time it's been up there and got passed this year, that says if you sell insurance in Kentucky, you have to cover the colon cancer screening, including colonoscopy. Now, it doesn't get into the specifics of your copays and all the other barriers, but it does say you got to cover it. The second is House Bill 415, and again, you'll notice that these essentially passed unanimously, which is a great, you know, our legislators, any legislators here? No, well, okay, well, don't tell them I said this, but essentially, you know, they tied the noose so that at the next session, we're going to be able to talk to them a little more about where that money needs to come from. Because they voted for this unanimously. Apparently they got it, you know, but translating that into funding is going to be an ongoing process. But what it does is does 2 things. Number one, it says for those 85% of people who have insurance in Kentucky, we are going to create a consistent, persistent, statewide message that encourages them to get screened for colon cancer, period. It's not complex. You know, we don't need to over-manage this message. It's a simple message. You know, people have a colon, colons get polyps, polyps turn into cancer. Do the test, find the polyp, skip the cancer. That's a very simple, straightforward message. But what it also is done in an unfunded way to begin is to help provide a program based upon breast and cervical cancer screening work for those who are uninsured so they can get access to this. I mean, I do not know why all 50 states have a breast and cervical program for the uninsured, yet 0 states have a program for colorectal. There is no logic to me behind that except the effective advocacy of women's groups, which I appreciate. That's why we're here. We're now going to take up that advocacy role, and we're going to talk about it. It's not yet funded, but we're working on it. The advisory committee is already meeting, and we'll have our first formal meeting after the Dialogue for Action. But you know, people don't like to talk about colon cancer. I'm gonna demystify you right here. But, colon, poop, poop, poop. Okay? You know, that's it. I mean, if you're still having trouble, let me know. We'll do it again. It's just not that big a deal. Well, here's what we're looking at here in Purchase. Okay? These are the 4 cancers that have screening modalities that are accepted by the U.S. Preventative Task Force Services. These are the ones that the government says work. Prostate is still very tough. My gosh, what do we do with a cancer that affects 75% of people over the age of 75? I mean, that's hard. You know, I don't know that. But here they are. Breast. Where are we here for you guys? Breast, 26%. Prostate, 20%. Cervical, a sliver of mortality. And colorectal cancer, 52%. So well over half of the deaths from preventable or at least early detection strategy things in your hometown are from colon cancer. And this is directly attributable to one fact. People are not getting screened for colon cancer. Now that's it. We can't change that linkage. You can't restudy it and recut the pie to get over that fact. So then the question becomes, how do we increase screening rates? Because we know it'll work, but we've got to get people in to get screened. But this is a stark fact, and all of Kentucky looks like this. I do think, though, that from a colorectal standpoint, the Purchase District is the worst of the ad districts in the state, but not by much. Everybody's right around this thing. But here's some facts about colon cancer. Second leading cause of death in the United States. I could go to any professional organization and ask them this question, and 80% of people would get this wrong. 80% of people would get this wrong. They would say breast cancer is the number one killer, or lung, but they would very few people would say colon. We know it's a man's and a woman's disease. We know that women are a little smarter about getting screened than men in most cases. Normal risk people develop colon cancer. In other words, no family history. That's 80% of colon cancers, just come out of nowhere. 20% of colon cancers happen in people who have family history. So the point is, if you have no family history and think you're protected, think again. It's not the statistics. Everyone's at risk. We do know that age is the predominant factor, and people over 50 is that when we get it. I do think we'll eventually move to 40, by the way. Why not? It takes us 10 years to get people to get a colonoscopy. Why not start in advance? We know it affects all races, but the effects worse in African Americans, for sure. And then this is, again, lifestyle related. And the American Cancer Society estimates for 2008 we're going to had about 150,000 new cases and about 50,000 deaths. And that is slowly declining nationally. If you look at the curve, we are making national progress that is not reflected in the state of Kentucky. And in the state of Kentucky, we still have more people dying of colon cancer than breast, plus cervical, plus TB, plus HIV combined. Now, why this is not priority number one in public health, outside of quitting smoking, which should be priority number one. It should be priority number two, I would say. I don't know. But in America, that's not the case. Treatment costs, again, we're spending tons of money. I think with Avastin and Erbitux, we're now spending more on colorectal than breast, but it's about the equivalent, $6.5 billion a year. $6.5 billion a year. Problem is we're spending it on really expensive chemo and advanced procedures and not on screening. You know, you say that the state's not spending any money on colon cancer. Well, we spent $7 billion on Kentucky Medicaid in 2007. $7 billion. I promise you a huge slice of that, given our mortality statistics, was on advanced colon cancer. So we are spending your tax dollars on colon cancer today. You know, the problem is we're spending it on treatment, not on prevention, or we're not investing in prevention so we can minimize treatment costs. I don't want anybody who's got the problem not to get treated. And this is why it's so important, because, you know, everybody has a colon. That's this first part. I'm going to make sure I don't kill myself here. Everybody has a colon, right? You get a genetic mutation, all right, and then you get a polyp. And then that polyp gets a second genetic mutation, and it revs up and it becomes cancer. But this happens for most people, the vast majority, over a decade, give or take a few years. And we know that this starts happening around the age of 50. So, you know, we've got a great window of opportunity, just like cervical cancer goes from, you get an infection, then you get low-grade dysplasia, then you get high-grade dysplasia, then you get early cervical, and very, very seldom, then you get late. That's why the pap smear works. I mean, this is a pap smear for your colon. I just want to keep going back to that, and then I want you to look at that disparity between mortality that's 52% versus 2%. And the question is, are we going to take 50 years to do this? Or are we going to get together and focus and concentrate and do this in 3 to 5 years and get this thing taken care of off our list? It just depends on what you want to do. Lifetime job? I don't want a lifetime job. I want to get this done so we can get on to some other important things like researching pancreatic cancer or whatever it is. This is something we shouldn't be spending a lot of effort on outside of increasing that screening rate. So let's go through some definitions for those of you who might not be familiar. A polyp is a growth, okay? Not all polyps are malignant. Some are not. They can be flat, they can look like a little bump, or they can look like a mushroom. All right? They start off small, they get bigger. This is what they look like. Screening means looking for people who have never been known to have cancer or polyps, and you're looking out there into the population to find out who they are to see if they have this problem. Surveillance is for people who we know have had previous colon cancer or previous colon polyps, and we know they're at an increased risk, so we're following them more closely. Unfortunately, we do lots of surveillance, and we're falling down on doing more screenings, and that needs to be the paradigm shift to where we're using our resources endoscopically. Can you prevent colon cancer? Well, we can certainly do things to reduce our risk. You can eat great, fruits and vegetables. You can exercise. You can avoid obesity. You can not smoke. Colon cancer, anybody aware that is a smoking-associated disease? About a 20% increased risk of colon cancer for smokers. Are there other drugs you can take? Well, some people talk about aspirin, calcium, selenium, folate, manganese, vitamin D. Wasn't it just 2 years ago that vitamin D was going to cure half of the cancers in the United States, according to the New York Times? Everybody remember that article? We haven't seen it here. The point of it is that none of these things change the recommendations for screening or surveillance. They're all great things, but no one says don't get a colonoscopy or a screening test at age 50 because you happen to be a vegetarian. Treatment options. This is really important. This is at the core of what we're doing. And again, I want you to think about this. You know, prostate and breast cancer is an early detection strategy. We try to find cancers early. They're already cancer. They're already cancer. And we try to find them early when we can treat them. Okay? Cervical and colon, we try, because we know what the precancerous lesions look like, you know, we try to find the precancerous lesions and address them, or at worst, find them early. Okay, so again, I always sort of have breast and prostate over here and colon and cervical over here as a comparative strategy because they are so similar. So treatment options, this is the best one. You have a polypectomy and you go to lunch. That's the best treatment for colon cancer. Okay, and that's what you normally get at age 50. As you move on, it's not always as easy because things have had a chance. We can take out even early cancers endoscopically, and God forbid you have an early cancer. Nowadays, many folks can take that out laparoscopically, and we can get that out, and you can move on with your business. You know, it's a very short recovery stay. Now, that's early cancer or polyps. What happens with late cancer? Well, chemotherapy, radiotherapy, resection, stenting just to help their bowels stay open, to help them, not to help them live longer, just to help them with their elimination habits. And then, you know, the work we're doing with liver metastasis, you know, we're cutting out halves of livers, we're microwaving them, we're cryotherapying, we're putting in chemotherapy pumps, we're doing all this stuff. And let me tell you guys, this stuff is not cheap. You know, chemo is like 10 G's a month. You know, one of these radio frequency things where they microwave it is like $25,000. I mean, costs for treating advanced colon cancer range from $120,000 to $300,000. And the cost for prevention of one of those colon cancers through screening is about $30,000. Now, if you believe in return on investment, this is a huge potential return on investment for our society. It is your tax dollars in Medicare and Medicaid, you know, if nothing else, you know, as a concerned citizen. Now, this is the part where we need to get, how many people here in public health? Okay. In the private sector, we undergo a continual process called transformation, where we are looking at where we're spending resources, capital, money, people, and what we're getting back from what we're doing. And as the market changes, where you put your resources change. And that's a continual process for a successful organization. These are the 10 leading causes of death pulled directly from the CDC. Heart disease, cancer. You can just take this cancer, by the way, and put in lung cancer, and it'll be the same statistic, because about 155,000 people die every year of lung cancer. Colon cancer is the 9th leading cause of death in America. All causes, all ages. And if you look at the ages between like 45 and 50 and 55, you sort of break it down, it can be as high as the 5th leading cause of death in those categories. So my challenge to you is, are we spending that appropriate amount of our resources, time, and energy, directing it towards this most preventable of cancers, or is it still stuck on the list of things that are hard? And we just don't do. And we just can't figure that out. You know, this is a mystery to us. We don't know what to do. You know, it's not a mystery, it's a puzzle. It's a hard puzzle. Otherwise, they would have already gotten it by now. You know, puzzles always have an answer. Mysteries don't always have an answer. You can't always figure out a mystery. This is a puzzle. But I don't want anybody to walk out of here and think that this is not a public health problem. Not somebody's pet peeve that they want to work on. This is public health problem. In fact, if you look at increasing screening rates or compliance rates with health behaviors, and again, I've said it, I'll say it again, smoking is the single most important thing that we can do. We get most people to quit, we'd save 1.3 million life years, not lives, life years. Okay, this is not lives, these are live years. What's number 2? Colorectal cancer screening. By a factor of almost 3 over increasing breast and cervical. We're doing a great job on breast and cervical. Getting 80% of people screened in Kentucky. I mean, you guys ought to give yourself a hand. That's amazing. But we shouldn't spend every single last penny trying to get those last 20% in, who I would suggest you could send a limo to with a check to pick them up, and they're not going to come. And so eventually you got to say, where are we going to shift resources within our budgets? And by the way, being against it is great. Having a budget line to do something about it is more effective. You know, don't send an army to battle with no guns. And guns for colon cancer is screening. Now that's just, I can't change it. That's the way it is. Influenza is huge health care, and actually for all of you guys over 50, you'll be taking an aspirin because it's second really only to, here I didn't put it up there, but you can save a ton of lives from stroke and heart attacks by a baby aspirin every day over 50. Again, back in the public health modality, you know, where are we spending our money? Well, if you have a gender-associated cancer in America, you're in. You're in with the feds. And they're going to spend money, and that's basically per case and per death we spend on breast and cervical and prostate to a much, much greater degree than we do on colon or lung or pancreas. And I will tell you, 27% of the NIH budget for colorectal cancer is spent on screening and early detection, and 73% is spent on a whole bunch of other stuff. And I would argue that, you know, we ought to change that ratio. And we ought to be spending, does anybody here think that we shouldn't be spending as much on colon cancer as we do breast cancer in our national budgets? Does anybody, I mean, seriously, I'm not, you can disagree with me, it's okay. But I just want to say, because if there's someone out there, I have not found the logical reason why we're not spending as much or more in the NIH budget as we are on breast or cervical. Cervical is a great investment. I want to spend on cervical. We spend $22,000 per death on cervical cancer, and that's money well spent because women are not dying of cervical cancer because we spend money on it. I love it. But I just want you to go through here, and this is from the New York Times, Tara Parker Pope. I'll make all these available if we got a jump drive, and you can have these slides and take them and either put them on the show or have them available. But these are the stark statistics. And I mean, to me, this leadership problem comes from the top down. You know, our guys in Washington, I think, ought to be looking at the list and looking at the list of return on investments and lives saved and investing accordingly. But they haven't. And that's where advocacy meets legislation, if you will. Because the only way it's going to happen is if we're on these guys. And we don't want them to not spend on breast. That's not what this is about. This is not about not spending on cervical or prostate. This is about saying, where can we spend our cancer prevention and treatment dollar most effectively? You know, and we know that treating lung cancer isn't an effective way to manage lung cancer. Preventing people from smoking or getting them to quit is effective. So as we look in our organizations, I want you guys to really look in there. You know, how much time are we spending on tuberculosis? You know how many people died in the last 5 years in Kentucky from tuberculosis? 72. Do you know how much we have in our state budget that filters down through the various things for tuberculosis? 15 million over 5 years, to about 3 million a year. So 3,072 deaths, 4,500 deaths of colorectal cancer, 0. I'm not going to go through this in detail, but let's talk about it. These polyps up here in these early cancers, they have no symptoms. 1 in 4 people here have polyps. So 1, 2, 3, 4. 1, 2, 3. No, not you, Doc. You've had your screening. But that's the number. 1 in 4. All right, and that's why colon cancer screening is so hard. You don't have any symptoms here. You don't have bleeding, you don't have abdominal pain, you don't have anything. But this is the only time you're going to fix this problem up here. Down here, you're going to have a fight for your life. And this takes a decade or more. And that's why these stories, does everybody get a DVD? I want everybody to take home to their organization a DVD. If you could help us, if you've got 4 or 5 people who are going to be using it in the same place, just get one. But please, everybody, take a DVD home and watch this story, because these survivors tell it so much better than I do. Bill Beam, our new president, you know what his biggest problem he had when he was diagnosed with almost advanced colon cancer, not screened at 57? He's afraid, he didn't know what to tell his daughter who was going to have a baby, that he wasn't going to be there. I can't tell that story. But that's the story I hear over and over again. That's what drove me, it's what drives me, quite honestly, is going out and telling the 2 57-year-olds on Memorial Day weekend that I had to tell that they had advanced colon cancer. It's a bad walk. This isn't going to shock anybody. Early cancer, great survival. Late cancer, bad survival. You can look at the cost, and it'll be just the same here. Cost a ton to treat colon cancer, and it's extremely ridiculously inexpensive. Well, but a colonoscopy is really expensive, right? Really expensive. My gosh, I can't afford that. But if you look at it on a strategy now, which is every 10-year colonoscopies, okay, it actually is less expensive than fecal occult blood testing strategies. It's less expensive than mammography per member per month. This is from the American Cancer Society, our partners in this. Annual screening mammograms for breast cancer cost 75 cents per member per month. Colonoscopies, 55 cents per member per month. FOBTs and flex SIGs, 47 and 66. All right, it's less than a flex SIG. It's a little more than that. But, this is not an expensive proposition for us. If you've got cable and your cell phones and all that kind of stuff, this is your health you're talking about. And you got to find a way to invest. And we got to find a way to break down barriers and get insurance companies to lower those copays and stuff for that first colonoscopy, particularly the first one. That's the one that really saves your life, is the one you get when you're 50, not the second one or the third one you tend to get when you're older or you've had polyps. We just don't find that many cancers then. But we can afford this process if we're willing to invest in it. Here's Kentucky, by the way. And again, the success and cost effectiveness exceeds all of these other, every single one of the cancers we've talked about except cervical. Because we know cervical works so well. So it's a better return. But unfortunately, less than 50% are getting screened. In Kentucky, for colonoscopy screening, it's in the 40s. And if you're docs out there, or representing docs, or working with docs, it's the #1 failure to diagnose cancer lawsuit right now in America. What do you mean I'm 56 and you never referred me for colonoscopy and now I've got advanced colon cancer? I mean, I have a hard time going in and saying anything about that case anymore. I can say something if you missed one. I can say something if, the test that they didn't work. There's certain error ratios, but I can't defend not recommending that people get screened and documenting. I can't defend that anymore. If you got positive blood in your stool and then they ignore that, that's a bad case. So, and ignoring rectal bleeding in any age person where you just say, oh, it's hemorrhoids, take a couple things and go home, that's bad medicine. You're 40 years old and you got rectal bleeding and your doctor tells you, oh, it's just hemorrhoids, don't worry about it. Try to reopen that discussion with your doctor. And if not, I would recommend you get checked. Because 10% of cancers are in people under 50, 10 to 15%. And it's bad. Now here's the new ACS guidelines. God bless the ACS. Who's here for the ACS? God bless you. You guys do good work. I wish we did clearer work. With colon cancer, we have so many different options that we have muddied the water. And what we know that from other successful programs in states and communities, you have to pick your best screening test and stick with it and pound that message in. And then if someone wants to use another test, then just talk about the other options. You don't want a colonoscopy? Okay, that's fine. Well, you know we can do these other things, okay? And even if you decided on a purchase-wide fecal occult blood testing program, no problem. Pick it and stick with it and keep it simple. Don't sit there and try to have someone understand this when they don't even have a, they're not going to do it. But basically there's two types of tests now. There's those that find polyps and cancer, which are endoscopic treatments for the most part, or visual things where you either do a flex sig, a barium enema, a virtual colonoscopy, or a colonoscopy. And then there are those tests that find cancer, and those are mainly fecal occult blood related. So I would argue that I would rather be in the business of finding polyps and removing them and cancers. So my tendency and bias is over here. But if people will do this, we're still going to reduce mortality because we know it works. So God bless the ACS, but I think we ought to have a clear message about that. And I think that if you told women there were 6 different options for breast cancer screening, you know that'd be tough. I mean, now it's mammogram, age 40. Mammogram, age 40. Mammogram, age 40. That's why we've made the progress. Now, for those in both health, so who's in the health department? I know you are. What percentage of your people are insured or uninsured?
Probably 85. You talking about the general population?
Yeah, coming in to see you guys.
15% uninsured.
15%? Oh, yeah, here, but how about the people who come to visit you through the health department? 85, the other way around?
Yeah, probably the other way around.
Okay, all right. I was in Bowling Green last week, and somebody said, well, 55% of the people who come to my health department, they don't have insurance. Well, what I said was, well, what are we doing for the 45% of people who do have insurance? When I look at this problem, I look at a big old rock, a boulder, and I know I can't move that boulder. So I am absolutely not going to waste my time trying to move that boulder. I can go around the boulder. I can climb over it. I can go get some friends who might help me. I can rent a bulldozer. I can blow it up. But I can't move the boulder. So I'm not going to focus my whole life on what I am absolutely incapable of doing. And what we've got to do in public health is realize these barriers, maybe the things that we can't do today, but we can still get around to that process. And that's what all of us have the challenge to do. Not what we can't do for the 85% perhaps, but what can we do for the 15% that do have it. Every Medicaid patient ought to be asked about this. Every passport patient in our area. Every Medicare patient who comes in who's got coverage. There are people we have coverage and we can move them towards that thing. But in doctors' offices, it's generally not a democracy. It's a dictatorship. In my office, every single person gets asked about colon cancer screening before I even see them, and it's documented. And I have a person whose job it is to do that. And when she doesn't do it, she knows, particularly she knows with me, that's not a good thing. Okay, but a team approach on how to do it best is great, where you reach out to people and you get folks to say, okay, how do we do this best? Because this is our new priority in our office setting. You got to implement a policy. And what we do is we take cancer screening as a vital sign in our office. So you're taking the blood pressure, pap, mammo, prostate, colon, even though I'm a gastroenterologist. We ask those questions. Up to date with your screenings. Takes 2 seconds. And just like a doctor will treat a blood pressure that's circled, that's elevated, I think most doctors, if they had a good system in place, they would go ahead and refer for a pap or a mammo if the person would accept it. And if nothing else, it allows you to document that you've talked about it. So there's a risk management benefit to it as well. And, people don't go and buy something the first time they see it. It takes time after time after time. 7 times you got to hear a message in marketing before it changes your behavior. So, again, that's great. Reminder systems are great. They're not perfect. But again, you got to have this communication. So, like I said, if you're in a doctor's office or running a health department, it's policy. It's our new policy. Over 50, we're talking about this disease. You're not going to get out of here even if you come in for influenza vaccine or a mammogram or an STD treatment or whatever. You're not going to leave over 50 without this question being asked and us trying to move you towards something. So what can we do in Purchase, in Paducah? And by the way, I want to compliment whoever's in charge of the Arts District marketing, because I've been reading about the arts districts and the quilts and everything else, I think from Madisonville, on those brown signs as you come in on the WK Turnpike in 24. You know, and I wish I had time to stay today, but we're going to Madisonville. But what I have learned is that, like so many things, like we've learned in breast cancer and HIV, you know, change happens from the bottom up. You know, the NIH has had these guidelines in Washington for a decade now. We're a decade into this. Yet, you know, it's not filtering down. So what I would challenge each of you all to do as you leave here is to look and start locally. You know, and what's the best way? Well, if you're over 50, and I will guarantee you there's people in this room today who are over 50 who have not had their colonoscopy. I mean, I can actually pick you out if you want me to, but I can do that. I've done this enough where I can look at you and know that you have or haven't done it. All right, so I would argue, number one, start with yourself. All right? And if you've had a family member or somebody who hadn't had it, talk to them. I mean, hopefully I've convinced you that this is not a big deal. And you'll see on the video a lot of stories that will tell you what a big deal cancer is. All right, so number one, start with yourself and your family and your friends. You really can make a difference. Every 100 people who go, who've never been screened, one of them has cancer, early if they're asymptomatic. About 2 more of them have big polyps that may either have to be cut out or maybe you can take it out with a scope, but still not cancer, but big polyps. And then about another 25 people have polyps. But 75% of people don't have anything. That's good news, great stuff. All right, but that's the real number. I mean, that's 1 in 4. Like I said, we can count them over here. You're too young. Actually, all of y'all are too young. I'm not going to even count on this side. Where else do you start? Well, you start with your business. You know, anybody here who owns a small business, well, you better be worried about your employees if they're valuable. You don't want your 50-year-old guy who's got all the institutional knowledge of your company coming out with colon cancer, and then you're paying disability, you're paying all these other things. You've lost a person, you've lost a friend or whatever. So your business. How about your church and your schools? You know, your hospital and health department, where they're all represented today, and I think that's extremely important. Physicians, nurses, allied health. I personally think nurses are part of the hugest part of the solution, because we can do things as a nurse that doctors are just stubborn about and won't do. You know, they don't, I don't do that. Well, nurses will do stuff. They'll take your blood pressure every time. They're not afraid of doing an intervention systematically. So I reach out to allied health and nurses. Chamber of Commerce. This is an economic issue. You know, I won't put the slide back up, but, you know, if you don't think that many people dying from colon cancer in your area is an economic issue for you, I got bad news for you. It is. So your Chamber of Commerce needs to be engaged. Your top employers need to have a visit from KCP people about what their policy does and how it changes and how we can increase the rate of screening. Your media outlets. We got media here today, which is great. You know, we'd love to do a Catch a Killer down here with some local folks and local stories. You know, we'll get this to you all so you can take any clips you want from it. But, you know, the bottom line is, you know, and this is the question I always ask. You know, when people say, well, we don't have time. I go, well, what do we do every October? What do we do every October for breast cancer? How many walks do we have? How many media events do we have? How many walks throughout the year do we have? What do hospitals do? You know, I don't think it's unfair to ask this question about why, given these statistics and these numbers, that we don't try to right-size our messaging and our expenditures on these outreach events. I don't think that's inappropriate. I think it's very appropriate. But it's not going to happen if you don't talk to them and you got to make a big deal of it. Because this is hard. Poop, 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 colon, 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 you know. I mean, nobody likes it. But it's not that big a deal. Same way breast and cervical and vaginal exams and everything was 20 years ago. It's just like it's a replay. And a replay for prostate with men and digital rectal exam. So are you going to let it happen? Finally, you got to get on your legislators to fund these bills and get them to quit saying there's no money Oh, I'm sorry, I just spent $7 billion of your tax dollars on treating all these diseases while they're advanced, but there's no money to do any kind of prevention. We just can't do it. Well, I don't accept that. No company would miss the opportunity in the real world to spend down on a problem they could cut dramatically with investment and say we can't do it because we spent dumb last year. It just doesn't happen in the real world. And finally, develop a team. The Colon Cancer Project isn't here to replace public health or the ACS or our legislature. What we want to do is get people engaged in this problem so we can develop a community solution. And Paducah's got to develop its own solution. I cannot come down here and give you a piece of paper and say, here's your solution. You all have to develop it yourself. But you have to do it by becoming engaged. You can't do it by just being against it. You got to be against it first and then follow it up with resources to change it. And that's the only way it's going to happen. It's the only way it's going to happen. And then finally, you guys have made such a great difference in so many people's lives over time. Don't be afraid of reinventing yourself. It's healthy. I can't believe people are in public health I know that they want what they do to be relevant. Otherwise, they wouldn't be there. They'd be doing something else. But sometimes all of us get a little, stuck. This is the opportunity to reinvent what you're doing and not see lives 20, 30, 40 years down the road, but see things within 3 to 5 years. We can make a difference in this disease in our lifetime in a very short period of time, and I would encourage and engage all of you all to take it up. Because women get breast cancer, women get colon cancer, your men get prostate cancer, men get colon cancer. This is your family. These are your friends. How many people here, last question, have had colon cancer affect someone who's a friend or part of their family? And I want everybody to look around. Hold them up high, and look around the room. That's 2/3 of this room. Now, those are the facts, but you guys can change it. Thanks.